Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. It's September 19th, 2024. Today we will be talking about the Medicare Advantage supplemental benefits. Before we begin, I wanted to remind listeners we have two upcoming virtual events from Health Affairs. One will be held next Tuesday, September 24th, and that focuses on the future of telehealth and its impact on primary care. And on Wednesday, September 25th, we have an Insiders Only Journal Club event where Molly Beinfeld will discuss biosimilars and their impacts on cost and market choices. You can learn more in the show notes. Today on the program, we have Kathleen Haddad. Kathleen, welcome back.
Hi, Jeff. Nice to be here.
Yeah, so open enrollment season, everyone's favorite season, is almost upon us. Is that correct?
Correct. It begins October 15th, and that's about 3 weeks from now. But, Jeff, even earlier than that, in about a week, insurers will begin releasing their plan options for 2025.
Exciting. That's exciting. So what do we expect this season?
Well, Jeff, the plan choices are likely to be different, and they may be confusing for some beneficiaries because large insurers are expected to drop some plans, some benefits, and yes, some beneficiaries. Insurers and health industry analysts say enrollees have been using more benefits than expected, and insurer profit margins are dropping. Another impetus for MA insurer retrenchment is that CMS will begin phasing in a small 3-year reduction in plan payments, and CMS has made it harder for plans to earn bonuses for quality.
Okay, so that sounds seismic. Would you say that's seismic?
I would say it's close to seismic for, depending on who you are. Beneficiaries may have a little more trouble this season because there may be different choices for them.
Interesting. Well, thanks. And speaking of choices, one of the things in these plans are supplemental benefits. So let's focus on that real quick. What are these supplemental benefits and why do they play such a major role in MA?
Well, that's the focus of the changes in the MA plan offerings this open season. These supplemental benefits are not part of routine health coverage. They're benefits like vision, dental, hearing, transportation, and even in-home support services, such as adult daycare, home health aides, and home modifications. They're funded from rebates and bonuses that plans receive from CMS when they demonstrate high quality and charge premiums that are lower than CMS expects. And they are often free to beneficiaries, and plans have used them to target and to market to get more beneficiaries signed up. The original purpose was to encourage MA plans to increase efficiency and value and return any savings to beneficiaries.
Okay, and so how much does the government pay for these benefits?
$64 billion a year. That's a good chunk of MA costs. That's 17% of what the government pays MA plans for all Part A and B services. Policymakers hope these types of supplemental services can help beneficiaries age well and stay in their communities as long as possible. Over this past several years, to that end, CMS has broadened the scope of permissible supplemental benefits. Offering more of these benefits has enabled insurers to attract more enrollees, so that MA now covers 54% of all Medicare beneficiaries and a disproportionate share of lower income and minority beneficiaries.
Okay, great. So you have some news, I believe. Health Affairs is launching a forefront series on supplemental benefits, correct?
Right, Jeff, right.
Great. And what does this series add to the policy conversation?
Jeff, this new series, sponsored by the SCAN Foundation, aims to examine all aspects of the role of supplemental benefits in filling healthcare needs. In fact, we published the first article just this week, an overview written by Eric Roberts and Bob Burke of the University of Pennsylvania and me. The article lays out the many challenges these benefits pose. There are so many concerns about how they're financed, how they're marketed, whether beneficiaries can actually sort through and make good choices and use the benefits, whether they improve outcomes, how state Medicaid programs coordinate benefits that overlap with Medicaid services, and whether the benefits are equitable.
So when you think of these concerns, what stands out as the most important to you?
Well, Jeff, it depends on your perspective. If you look at this from the beneficiary point of view, at first you might be excited that you can get all of these additional services free from so many plans. But the average beneficiary has 43 plans to choose from. All these plans have different levels of cost sharing, different provider networks, different limits on the duration and dollar amount of services. And there's also little knowledge of whether the beneficiaries actually use the services they're entitled to.
Okay, so you mentioned overlapping benefits between Medicare Advantage and Medicaid. That sounds like there's some potential for complications. What's going on there?
You're absolutely right. There are at least two issues there. First, the most common Medicare Advantage supplemental benefits, dental, vision, and hearing, overlap with Medicaid benefits because most state Medicaid programs provide these services. So, MA enrollees who are also eligible for Medicaid and enrolled in special MA plans called D-SNPs have to navigate two insurance programs. And this can be a headache both for the enrollees and for state Medicaid administrators. Also, there are enrollees who are eligible for long-term services and supports in their MA plan and Medicaid. And coordinating these services is difficult. In fact, in some cases, it can lead to denials from both programs out of confusion over the coverage rules.
Okay, so are there any solutions to these problems?
Well, I'm glad you asked. The lead authors of today's Forefront article, Eric Roberts and Bob Burke, lay out several proposals for CMS and Congress to consider, and they outline where more research is needed. For example, we need to know more about how beneficiaries make their plan choices. If it were me with that many plans, I might just throw a dart against the wall. Um, but if we know more about how they're choosing, that can inform regulation of benefit offerings and plan marketing. And the article also suggests standardizing benefits to make choosing plans easier. That would be something like the tiers in ACA plans or the categories in Medigap plans. Already, CMS has required plans to begin submitting encounter data when supplemental benefits are used, and that would help to answer many questions about how beneficiaries use benefits if they use them. One interesting item about this encounter data is, that's going to be a little difficult for the plans. They can do it, but they might need some support. Some of the beneficiaries or some of the benefits don't even have CPT codes for those services. And so it's hard to know how to record that those actually happened.
And so what should beneficiaries do during this upcoming open season?
Well, that's a good question. There is the SHIP program. I believe it's run by each county, the state health insurance program that helps counsel beneficiaries when they're having trouble choosing. In fact, if the insurers do offer fewer plans, that can cut two ways. It might make it easier to choose plans, but some beneficiaries will find their current plan is not offered. And if insurers cut back on supplemental benefits, as some are signaling, then access to some benefits would be impacted.
Well, Kathleen, thanks for joining us today here on Health Affairs This Week. As we're wrapping up, I'm sure some of our listeners might want to know how they can submit articles to this supplemental benefit series. If they have some great insights on the topic, how might they be able to do that?
Right, Jeff, I'm glad you asked. We want to hear all voices, and we welcome submissions from all perspectives for this series, whether you're a health insurance company, a healthcare provider, an MA plan, a Medicaid administrator, a beneficiary, a counselor to beneficiaries, a vendor of supplemental services, or if you play some other role. So please feel free to submit and get writing. We will be accepting articles on a rolling basis throughout the year, and you can find submission instructions on the Health Affairs Forefront webpage.
Well, fantastic. Thanks for sharing that, Kathleen. We'll be sure to put that in the show notes. Thanks again for joining me today on Health Affairs This Week. To you, the listener, thanks for listening. If you enjoyed this episode, please send it to the Medicare eligible person in your life. And make sure to subscribe and be sure to listen to Health Affairs wherever you listen to podcasts. Thanks, everyone.